Okay, here we go through the rest. It's nearing the end, so hang in there. We're getting through it. All right. More decels. Very nice. Again, these are abrupt in their shorter in duration, so these are variables, but I've included the strip just to remind you that if you're having persistent deep variables like this, you need to suggest to the provider and try to coach your patient to alter their pushing efforts. So push every other contraction or every third, and that's why I have included this here. I think that the fear for some of the providers is they don't want to slow the process down, so they don't want to turn their pit down, but you do what you think you need to do for your patient safety. And towards the end of this strip, it looks like maybe that patient's not even getting a minute break in between contractions there. So if there's pit on, you certainly want to consider at least halving it, and for sure alter some pushing efforts there to give the baby a break in between. Here's a strip later after they've given the baby a break to rest, pushing every other contractions, and the patient had pushed 2 hours in that other view. Later on, closer to 3, and they put the vacuum on and had a baby born, APGAR 6 and 9, which shows a compromised baby, however, a good resuscitation, and so the baby had APGARs of 9 after resuscitation. Again, reminder for reducing uterine activity, where you have some compromised beginning, that baby's a little bit tachycardic, and then there's what appears to be, well, there's probably a combination there. That first one, it's not a great copy, but it looks like it's abrupt, so it's a variable, and the second one is looking late. You want to decrease or discontinue oxytocin or cervical ripening agents. Administer IV fluid bolus, and the fluid bolus can do 2 things. The fluid bolus increases your vascular volume, which pushes some fluid, towards the placenta, which will help some of that perfusion. It also, if you fluid bolus, it can lessen your contractions, and I have a slide later that shows how much more quickly you can decrease your uterine activity if you half your pit in bolus or turn your pit off in bolus. So you're going to want to think about that. Initiate some position changes, and if no response, you can suggest to the provider that maybe tocolytic would be in order, especially if you're category 3 and you're really just having some compromise and you see that baby is deteriorating. Normal uterine activity, less than or equal to 5 contractions in 10 minutes, averaged over 30 minutes. So you take your little sections and average them over 30 minutes. Tachysystole is greater than 5 contractions in 10 minutes, averaged over 30 minutes. Also, if you have contractions greater than 2 minutes, a normal contraction pattern, but you only have 1 minute or less in between them. Oxytocin is the most commonly used induction agent in the United States and worldwide, and it is a high alert medication. Just a reminder of what happens when you have excessive uterine activity. If you have tachysystole, you have decreased placental perfusion and decreased fetal oxygenation. If a patient is induced, their risk for cesarean birth, if their first pregnancy, nulliparous, is a 2-fold increase chance of C-section. And if during their latent phase, where they're somewhat active, not active, if they allow 12 to 18 hours before they diagnose that it's a failed induction or arrest of, dilatation, it will increase their risk of C-section. But that's not anything that you don't already know. Within the body, there is endogenous, or your own oxytocin that your body produces. It comes from the cells in the hypothalamus and the posterior lobes of the pituitary. That there is ADH and oxytocin that's let down, and I guess the purpose of this is not to quiz you on what organs secrete oxytocin and things like that, but there is some that's secreted by your breasts and uterine tissue, but to show that there is circulating oxytocin in your body. The endogenous oxytocin that's circulating in the maternal body is similar to IV oxytocin at 2 to 4 milliunits per minute. And then on the fetal side, babies also secrete oxytocin, and that's something that's been looked at in research about why people go overdue, or why doesn't labor start, or why is labor dysfunctional. That perhaps that the baby's side of that, the baby is not signaling or letting down an oxytocin in a timely manner to make that labor happen or progress. So babies secrete similar to the mom's pitocin at 2 to 4 milliunits per minute. So the combined effect of maternal and fetal oxytocin is 5 to 7 milliunits per minute. And when you have a successful induction, it seems like you really just give them a little bit more. You aren't going to that higher dose. They seem to kind of go into that labor pattern somewhere around 4 to 6 to 8, and so you can see why that probably happens. Exogenous oxytocin, meaning the pit that we hang in our bags. Uterine response is usually within 3 to 5 minutes of IV administration, and the half-life is 10 to 15 minutes. It takes 3 to 4 half-lives, meaning at the minimum 30 minutes to reach plasma concentration and go to the receptor sites on the uterus. So in other words, 30 to 60 minutes for you to see a response when you increase it. So that being said, that's why we should increase it only as often as what we're supposed to, 30 to 40 minutes. And I'll go back to that in a minute. Like for the test, there is a question about what the half-life of oxytocin is. So you'll need to know that the half-life is 10 to 15 minutes. And then with that being said, that's why we don't increase so quickly, because it takes that long for it to be at the receptor sites. So the low-dose protocols that we use now resulted in decreased episodes of excessive uterine activity, increases the rate of spontaneous vaginal birth, decreases operative vaginal birth, and a trend toward decreasing the rate of cesarean birth. You should try to achieve the minimum dose you need to get active labor, and we all know that that is just a nebulous thing. You just can never tell what the right dose is, and your contractions are never like textbook. You get doubling, you get tripling. So what do? Do you increase it to try to break up that pattern and try to get it into a more regular pattern? Do you cut it in half? There's lots of schools of thought about that, but you just have to kind of watch that evolution of your strip to see, well, now I went up and it seems like it's better, and just keep it there and watch it for a while. So that being said, that's why we don't increase our pit any more than every 30 minutes, because it takes at least that long to reach the plasma level it needs to be into the receptors. Too much oxytocin, well, it's dosage and length dependent, meaning there's a certain dose that varies for every patient that is too much. It might even be only 2 milliunits, but you just have to kind of see how that goes. And it is length dependent. So if you have someone that has been on PIT for over a day or longer, those receptors get filled, and they get desensitized to it. So if someone's been on PIT a long time, you do see that you're requiring higher and higher doses to get the response you want. That's called oxytocin receptor saturation, or desensitization, or downregulation. And this is kind of what I just talked about. You have some tripling there with those contractions, and so what do you do for those? Do you up it and try to break up that pattern, get it into a more regular? Do you decrease it to see if that gets it apart, those spaces in between a little bit better? But I mean, in this case, you've got a variable here and there, so you should not increase it according to our policy. You could keep it that way, but you might want to half and start to go back up again. Just some safe practice standards that are included in A1, and I mean, it's not anything on the test as far as I remember about this, but A1 suggests that there are standard order sets and protocols based on current pharmacological and physiological evidence. You start at 1 millunit per ml, or 1 millunit per minute, and up it by 1 to 2, no more often than 30 to 60 minutes based on maternal and fetal response. And we have this safe practice in effect now. We have a standard concentration of oxytocin prepared by the pharmacy. We don't mix our own, and it is 30 units in a 500 ml bag. So that gives us 1 ml per hour, and that equals 1 millunit per minute. So when you set your pump at 1, you're delivering 1. When you set it at 1 ml, you're delivering 1 millunit, which is perfect. Then you don't have to do the math, and there's no confusion. Other safe practice standards have to go along with documentation, meaning you assess and you document every 15 minutes in the active phase and every 5 minutes in the active pushing phase of second stage labor. And they only include that timeline because they are now considered high risk. They're on PIT, and so it's every 15 minutes in the first stage and every 5 minutes in the second stage. Another flow chart to manage uterine tachysystole. If you have spontaneous labor, meaning you're not running PIT and you have a category 1, obviously you don't need to do anything. If you have spontaneous labor and you have a category 2 or 3, you do your intrauterine resuscitative measures, and hopefully if you don't get some improvement, you have to consider a tocolytic. You might be able to rest the baby and go back to an active labor situation, unless you progress to category 3, and then you have to consider delivery. So, and on the other side of this, if it is an induction or augmentation, meaning that you have PIT that you're controlling, obviously that you need to do something about that. You need to decrease it or something like that. So if you have a category 1 and you have PIT on, regardless of whether your tones are good or not, and you're doing an induction and you have tachysystole, you need to decrease your PIT. Your kid might look fine now, but again, it goes back to the idea about how much reserve really does that baby have, and how do you know that? You just don't know. It's like a gas tank without a gauge on it. You don't know, so you can't even hazard a guess. It might look good now, but if you deprive that baby of oxygen over and over and over, that baby is not going to be able to maintain. So going back to the induction or augmentation, if you have a category 2 or 3, you need to decrease at least by half or stop your Pitocin, and then you do your resuscitative measures, and if there's no resolution, you consider a tocolytic. And in the next slide it shows, I think is the next one that shows how quickly you should see some changes when you decrease your PIT based on the half-life. So you can base how much your interventions are effective and if you're going to have to completely turn it off or not based on how quickly that happens. So again, another one that's some tachysystole with some variables and probably a late there. So you're going to want to half or turn off your Pitocin. This slide, little table, talks about what happens when you decrease your oxytocin and what happens when you combine that with a fluid bolus. So if you completely turn off your oxytocin, you should see some changes and hopefully some improvement within 14 minutes there of turning off your oxytocin right here. If you DC your oxytocin completely and you also give a fluid bolus, you can see that your resolution of your pattern or change in your pattern is going to occur in about 9 minutes. That, you know, with the extra perfusion you get with the fluid bolus, and also it kind of dilutes out those receptors, so it's going to help get rid of some of that oxytocin at the cellular level and decrease the uterine activity. So that's great. And if you discontinue oxytocin, you fluid bolus, and you reposition, you see that you get some change in your tracing in an average of 6 minutes. So that's really significant. And that gives you an idea how long you want to continue to watch your tracing before you move to the next sort of interventions that you're going to do or think about an operative delivery. To restart your oxytocin, there is some recommendations, and our policies that we have follow the A1 guidelines and the recommendations from Knox and Simpson, which you see cited at the bottom. After you resolve your tachysystole, if you've had your oxytocin off for 20 to 30 minutes and you have a normal category 1 tracing and your uterine activity is back to normal, meaning no tachysystole anymore, you can turn your Pitocin back on at half the rate, no higher than half the rate. So you can turn it back on at half, and then you can gradually increase from there based on our protocol, which is the standard, 1 milliunit every 30 to 40 minutes based on how the baby's doing. So now your tachysystole has resolved and you want to turn your pit back on. Your provider wants to continue and see if you can get through this and deliver this patient vaginally. If it's been off for greater than 30 to 40 minutes and your fetal heart tones are category 1, your uterine activity is normal, then you can resume your oxytocin at the initial dose ordered. Here's a sample question. The primary goal in the treatment of late decelerations is to, and you have to go back to your physiology again, talking about each deceleration and what is going on, what's the physiology behind it. A late deceleration is not based on cord compression. Do you want to improve maternal oxygenation? Yes. But your initial thing is you want to maximize the uteroplacental blood flow. So the answer here is C. And you would do that by repositioning, fluid bolus, and altering your pit. So in order, number 1 priority, like for the test, if they say that you want to let's do that in reverse. Say that your goal is to maximize uteroplacental blood flow. What would you do first? Generally, your go-to response is decrease your uterine activity. So whether that be with a tocolytic or turn off your pit, or it's going to be to minimize your uterine activity and then maximize your flow by bolusing and things like that, and obviously oxygen too is further on down the list. But so here's a case to look at. This patient's dilated to 9, 100% plus 1, and based on the tracing above, what initial intrauterine resuscitative measure would be appropriate? Well, you have to look at what's going on. You have to look at your variable. And I gave you the answer. You have to look at your deceleration